afternoon to everyone. I would like to thank Dr. Simona for the opportunity to speak about this case report. I'm Feliciana Mena and I work in a moment at Kent Hospital of Arau. So, let's go to our clinical case. This is a case of an 85-year-old Swiss man. He's known for liver transplantation, so under immunosuppressive treatment. He is known also for an ischemic heart disease in outcomes of stent for inferior myocardial infarction and for a chronic renal failure. Not last, he is known for a squamous cell carcinoma of the skin of the left eyebrow, known since 2017. Few words about what is spinalioma. Spinalioma is a rare but very aggressive form of skin cancer. It's characterized by the ability to give metastasis. It's the second most common eyelid malignancy, and among risk factors and etiologies include aging, long-standing ultraviolet radiation exposure, cigarette smoke, chronic ulcer, and immunosuppression. For what concerns follow-up and prognosis, orbital invasion is a serious complication of aggressive lesions. Characteristic signs is the presence of ulcerated eyelid lesions associated with ocular motility restriction. Among 4 prognostic factors, these include poorly differentiated tumors, perineural spread, orbital invasion, and immunosuppression. It is a broad spectrum of clinical appearance of spinalioma presentation. We start from actinic keratosis until the metastatic carcinoma characterized by multiple nodular ulcerated lesions. So let's go to our patient. First of all, important to say that chemotherapy and immunotherapy treatments due to internal diseases that we have seen before were contraindicated in this case. But let's take a look on the clinical file of our patient. This patient made multiple surgical excision, palliative symptomatic radiotherapy at retroorbital level and left skull base. In May 2020 was seen a disease progression, unluckily, and in January 2021 there was the appearance of a skin fistula. That was natural, not a good sign, and the appearance of a total ophthalmoplegia. Currently, our patient is under palliative care. You will see now, I advise you, very strong picture, but it's very important really to understand that in this case it's extremely important to follow intensively the patient with a multidisciplinary team. So this is the actual situation, luckily, of our patient, where we can see that this spinalioma was so really aggressive. So what we can say about which are the take-home points. First one, to remember that spinalioma, squamous cell carcinoma, is a type of invasive and very aggressive malignancy. Second, it manifests as a spectrum of progressively advancing malignancies and can spread to the orbit, as we have seen in our patient. Third, not the last, really extremely important, the necessity for multidisciplinary collaboration. This is my reference. Thank you very much.
Good afternoon. It's a pleasure to be here with you. Thank you to Filippo Simona for the kind invitation. It's a pleasure to share this program. And I'm Letizia De Antonio. I'm radiation oncologist at the Oncology Institute of Southern Switzerland. And Filippo asked me to talk about the radiation therapy in paraocular lesions and which are the strategy about the treatments. A conflict of interest, some outlines that I touched during my speech. I don't bother you with our constraints and particular setting in radiation therapy, but it is really important to focus on the ocular structure and radiation dose volume effect that we need to consider when we treat a patient with a tumor nearby the eye. I will stress a little bit about the development of radiation therapy during the last years, and I discuss some paradigmatic cases, for example, a lymphoma of the orbital anexa, and a non-oncological disease, but that can affect patients and that can be treated with radiation therapy as Graves' orbitopathy, and then some cases of difficult, challenging cases of facial skin tumors. First of all, as a radiation oncologist, we have a dream, and our dream is to obtain a high local control of our disease with a low dose of radiation, and to protect very well our organs at risk in order to reduce at the minimum the chance to develop a side effect and, most important, long-term side effect. Radiation therapy plays a crucial role in oncological treatment. Is estimated that about 60% of patients that face an oncological disease need radiation therapy along the course of their disease, and so radiation is a very important part of the treatment. And especially there are a lot of tumor that grow in the orbit and nearby the orbit, and so as a radiation oncologist, first of all, before identifying our target volumes, we need to consider all the ocular structure that we need to spare, and in particular one part of our job is to contour and identify all the structure inside the eye, like the cornea, the lens, all the orbit, the retina, and the lacrimal glands, that are very tiny structures but really important, and we need to spare with our modern techniques. And moreover, we need to consider also the optic nerve and the optic chiasm as organs at risk. Why we need to do this? I don't want to bother you, but we need to spare the organs because the organs have a tolerance that cannot be exceeded, and we need to spare, for example, the chiasm, and we need to maintain the maximum dose less than 54 grays as a maximum dose in order to reduce the risk of optic neuropathy. For the retina, we need not to exceed a dose of 50 grays. For the lacrimal glands, we need, that is a very tiny organ, as you perfectly know, but we need to reduce a percentage of the dose at 30 gray. And moreover, we need to protect the lens that don't need to exceed the dose of 10 grays. And finally, the limit dose for the cornea would be 50 grays in order to reduce the risk of corneal damage. One point that I would like to stress with you is that in the last 15 years, radiation therapy changed a lot, and nowadays we have really treatment that can spare and can understand before the risk of the organs at risk and the risk of our treatment, and we can really perform a treatment that can try to deliver a very precise dose around the tumor, inside the tumor, and spare the organs at risk in a very satisfactory way. Some strategy that we need to face when we treat some particular situation. For example, one of typical example is the ocular annexal lymphoma, that are in general extranodal indolent lymphomas. Multi-lymphomas are the majority, and then they can grow in the orbit at the level of the conjunctiva, at the level of the lacrimal glands or the eyelids. I show you a case of mine, an 8-year-old lady that that arrived to our attention after an ophthalmologist consultation because she had a superior palpebral swelling, as you can see here, with palpebral redness and irritation, and after a biopsy, we discover an extranodal marginal zone lymphoma in a local stage 1 of the conjunctiva. The patient underwent a PET CT scan that discovered only the lesion at the level of the superior palpebra. And in such cases, radiation therapy is the main, the first treatment that we perform. We were very lucky because the patient underwent a cataract before treatment, as can happen in elderly patient, and so we perform a treatment, a very elegant treatment, covering the only anterior part of the orbit to a dose of 24 gray in 12 fraction, with a very good sparing of the optic nerve. And this was the result after the treatment, with a complete recovery of the lesion, and after 1 year the patient is free from disease and with any acute and latent toxicity. But we are not always so lucky, because in such a case the patient has done before the cataract, and so we not face the problem of the constraint at the level of the lens. Radiation therapy for ocular annexal is a standard of care with a very ocular annexal lymphoma is a standard of care with a very high local control, about 95-100%, with a long-term relapse-free survival in about 90% of patients. Nowadays, the standard of care is moderate doses at about 24-25 grays. We have some acute side effects like skin erythema, epilation of the eyelashes, conjunctivitis, but the risk of cataract is still high because 50% of patients risk to to develop cataract during the follow-up. Which strategy can be adopted? Well, one strategy is to spare some part of the orbit in order to perform the treatment. We don't need in every case to treat all the orbit. In some cases we can treat just the anterior part. We can perform elegant treatment with IMRT, and in some other situation we can also use a very particular, in some situation we can use also lens shielding, like in this case, that can be also customized in our department. And in such a case you can see with this lens shielding we treat this in red is the high dose at the level of the tumor, and then we can spare the other area. But our guideline suggests that we need to be really confident that we treat in a correct way the disease, and we don't risk to shield also the tumor. Another opportunity, another strategy is nowadays the de-escalation of doses, because we have the historical data with treatment up to 50 grays that nowadays are not necessary, with a very high local control but with a high risk of late effects. Nowadays we tend to reduce the dose to 24 days, not only in indolent lymphoma but also in the extranodal indolent lymphoma, but the risk of cataract remain quite high, 25% at 7 years. And nowadays one of the strategy is the so-called boom boom radiation therapy, 2 Glera plus 2 in a palliative setting, but that in some situation, for example in some retrospective and prospective data, we use also in a particular situation of the ocular nexal lymphoma also as curative, with curative intent. For example, the data that we nowadays have and we will expect with some trial ongoing is a very high response rate without late effects. So as radiation oncologists in this setting we need to spare the organs at risk, but also to de-escalate the dose would be really the most popular and maybe we hope the most effective strategy. Another situation is a non-oncologic situation, it's a Graves' orbitopathy. I don't bother you because you know better than me the biology of the disease, and it usually expressed with a mild and non-progressive case, but in up to 6% of cases we have a moderate to severe forms, and in such a situation maybe we need to treat the patient, and as our European guidelines consider first-line treatment corticosteroids, but in some situations they don't achieve good results, and so in second-line radiation therapy can be used as a treatment of choice, and we have symptom improvement in up to 74% of cases. And which strategy we use to treat this kind of patient. This is a patient that I treated 2 years ago. We treat with usually 20 gray as a cumulative dose in 2 weeks, and our target is the posterior part of the orbit, and with a volumetric modulated therapy we can really spare in a good way the lens and also the lacrimal glands in order to maintain the constraint lower than the limit, the dose to develop side effects. Another strategy would be, as in lymphomas, also in a non-oncological disease, to reduce the dose. And this is a not very recent paper, but this author tried to, in a prospective trial, to reduce the dose in order to skip and to treat the patient along 20 weeks, so a long amount of time, 1 gray per week instead of the standard dose of 2 gray per day in 2 weeks. And they achieve also good results in terms of amelioration of symptoms and control, and also a better response rate and adherence to the protocol by the patient. Moreover, I would like to share with you some challenging cases of periocular lesion, most of all, as discussed before by Feliciana, with they are very important for elderly patients, because non-melanoma skin cancer can affect the face in a lot of situations, and this is a situation of Merkel cell carcinoma. That is a very aggressive skin tumor that need a radical surgery and then always adjuvant radiation therapy at a quite high doses. And this is the scar, and we need to treat a quite large area around the eye, and this is our target and our dose distribution. We are very close to the eye, but with arc therapy now we can really spare, and here you can see the eye dose and then the dose that fall down in a very rapid way in order to reduce the dose to the organs at risk. Few years ago, such a treatment would be really difficult to perform in the same way. Another situation is a very challenging tumor of an elderly lady of 96 years old with squamous cell carcinoma between the medial canthus and the nose root. This is here, and surgery was quite impossible in such a situation, so we discuss in a multidisciplinary meeting how to approach, and we go through radiation therapy. We customize a mask in order to block the patient, and a customized bolus wax in order to superficialize the dose. And this is the final result, the treatment planning, also with a volumetric arc therapy, in which we treat with a very high dose the tumor, and as you can see here, the dose fall down rapidly at the level of the orbit. And because the patient was was very collaborative, we asked to the lady to try to extra-rotate the eye in order to move the lens far from the eye dose level. Here I don't bother you with this case because the patient that unfortunately Feliciana showed you that I treated and with Filippo 2 years ago with 2 irradiation, unfortunately that don't give good results. And we can also perform not only radiation therapy with external beam, but also with brachytherapy, and we can perform with many kinds of brachytherapy. This is the system called Xsoft that perform in an old lady with a recurrent basal cell carcinoma of the medial canthus with low energy, with 50 keV. We perform a treatment in a very few minutes. Every single session takes less than 3 minutes, and with this machine we can perform a contact brachytherapy at this level with customized applicator of different size in order to treat this area with a very rapid de-escalation of the dose from the surface. We have the 100% of the dose, and at 15 millimeters we have almost the 30% of the dose. Another situation when we have iridium wires, we can perform also radiation therapy with low dose brachytherapy with wires of iridium that consist in the insertion of wires in local anesthesia. And I have this experience where I worked before with interstitial brachytherapy, with a low dose interstitial brachytherapy of eyelid tumors with a very high local control, about 96%, with acute effects that are transient, an 80% risk of conjunctivitis, and late effects like stenosis of the nasolacrimal duct and obviously the risk of cataract. More nowadays, instead of low dose brachytherapy, we tend to use high dose brachytherapy with interstitial sources of 192 iridium, and this is an example of implant of brachytherapy and the results after 3 months. This is a very elegant retrospective study, and how we can spare the lens with a custom-made lid shielding that are applied every day during the session of the treatment. And we have really good local control, with local control in about 94% of patients, with the risk of late effects. Most the principal is madarosis and keratoconjunctivitis sicca, with a good results in terms of cosmetic. And in conclusion, as we before mentioned, the multidisciplinary and a detailed ophthalmologic assessment for radiotherapy is essential, because we need to know from which point we start. Nowadays, radiation therapy is very competitive, also with not only with brachytherapy, but also with the capacity of external beam radiation therapy to treat in a very elegant way in order to spare the organs at risk, and is safe and effective, and I would thank you for your attention.
I like to perhaps take the opportunity to address the radiation oncologist, because this is a discussion I also have with Dr. Pika. What I always see in talks about radiation oncologists, they're extremely worried about the cataract. And at the first slide, I was a little bit afraid when you said the retina get 40 to 50 grays, so while I already get nervous from 20 grays onwards. And we, ophthalmologists, from the moment that there is a cataract, we can operate. We have brilliant cataract surgeons. So that's something, yes, it's cataract, but we can cure it perfectly. We even, for refractive purposes now, will take out clear lenses. So on the other hand, retina, I mean, once it's ischemic, it's finished, it's done. So, and there, I don't know, it must be in the training of the radiation oncologists that they got still, whether it was still intracapsular cataract surgery that was going on, and the sensitivity is there, while we are not stressed anymore. And the retina, perhaps that there we should be, the patients are getting older, more cardiovascular diseases, so the threshold is getting lower, they survive much longer, so they have the time to develop the things. I don't know, that's something I notice in every radiation oncologist talk.
Well, that's true, but nowadays we need to be more, well, we were afraid about the side effect of on the retina and the cornea also, because we don't need to forget the cornea, because now we have long surviving patients. And so this is, we need really to contour this organ at risk, and not all of us are have the we don't always contour the cornea, the retina, etc., because we know that we are in about 50 grays, and so we are afraid about cataract. This is the reason why. But nowadays, also with the treatment with the stereotactic radiotherapy, when we push a lot the dose, we need to be really more afraid about that. No, that's right. That's a good point.
And to conclude a short history of the passion that we've followed together with Feliciana and Letizia, it was that the take-home message can be: don't hesitate to sacrifice the lens because there are good cataract surgeons, and don't hesitate to sacrifice the eye to save the life of the patient. Is a second thing. Unfortunately, despite the multiple surgical intervention by our patient, and after the radiotherapy, multiple radiotherapy from Letizia, the eye progressive disappeared. So the picture that you have seen are not the picture after enucleation, but no eye more. And unfortunately, the spinal leoma was so aggressive that penetrated the brain, and finally the patient died.
Any questions from you? Just one comment. You're absolutely right. These patients with active immunosuppression, they have such aggressive tumors, and we also see that in clinical practice as well. So we treat many patients, and regrettably, when they have active immunosuppression, the tumor is getting more and more aggressive. So what there is an interdisciplinary management is absolutely essential. We need to discuss with the other doctors, reduce the immunosuppression, and we have also seen that also the reduction with the immunosuppression, we can still activate a little bit the immune system. So there might be a very small response. Of course, these patients, they need an interdisciplinary treatment, and they should be discussed at the tumor board also for consideration of systemic treatment.
Thank you.